Hello, everyone. Thank you for joining us for what I hope will be an interesting and informative discussion about some of the most important data presented at EULAR in Vienna 2024. My name is Professor Peter Nash from Griffith University, beautiful downtown Brisbane, and today we're very fortunate to be joined by Professor Daniel Blockmans, who is from the Department of General Internal Medicine at the University Hospital of Leuven. It's a pleasure to have you join me today. Thank you so much for your time. And we're going to be discussing what's an abstract not yet published, but presented at EULAR, and I must say was really the most important new paper presented at EULAR, the efficacy and safety of upadacitinib in patients with giant cell arteritis, called the SELECT-GCA trial, which was a double-blind, randomized, controlled phase 3 trial. So, firstly, just tell us a little bit about yourself, Daniel, where you work and your background and what you've been working on prior to this study.
Yeah, well, I'm not a rheumatologist, I'm a general internist. These species still exists in Belgium, at university centers especially. And I've always been interested in systemic diseases, broad, and I'm also in charge of the course of systemic diseases at the University of Leuven, where I'm working. But especially, my special interest goes to vasculitis and GCA, giant cell arteritis in particular. I've been doing quite some work on diagnosis of the disease. I introduced PET scan for that purpose. Well, I've always had a vivid interest in GCA and how to treat it also, of course.
Excellent. And in your country, who would be the people that see most GCA? Would it be rheumatologists, internists, ophthalmologists, neurologists? Who look after GCA the most in Belgium?
Yeah, in the peripheral hospitals, it will be the rheumatologists. And of course, from time to time, unfortunately, also the ophthalmologist, who will be the first medical professionals who will see these patients. It's in university centers. It depends, rheumatologists or general internists.
Okay, and you said you pioneered PET scanning. Is ultrasound of the temporal arteries universal now in Belgium, and are biopsies being done less, the same, or as it always has been?
Well, in Belgium, it's I think it's maybe now PET scan who is the most prevalent technique done here in Belgium. It depends all on reimbursements. I know it's much less available in the United States, but here we can have easy access to it. Ultrasound looks more easier and doesn't have any radiation. Maybe it's cheaper, but you need a lot of experience. Is my experience with this technique. So ultrasound is not widely spread in Belgium for giant cell arteritis.
Okay, so let's talk a little bit about your study. Just give us a bit of background, how many centers around the world and which parts of the world were involved. I see Peter Merkel, Helen Keane from Australia, yourselves, who else?
I think there were 101 center or so. So it was in fact the largest study ever done in GCA. 428 patients were enrolled. And in fact, it's in all kinds of vasculitis, this study, with the exception of the PEXIVAS study in ANCA-associated vasculitis. And in that study, even more patients were enrolled, but this is the second largest study in all kinds of vasculitis and the largest study in giant cell arteritis.
And very challenging to recruit with a placebo arm that goes for a period of time. So was that a challenge, having ethics agree to a placebo arm?
The placebo arm, well, these patients got what is known as the treatment of GCA.
A standard of care.
Standard of care, yes, indeed. But it was challenging because it was the recruitment of these patients was during the COVID period also. And
Right.
well, nevertheless, we succeeded in including 428 patients.
Excellent. So tell us your objective. What did you start off trying to do, and what were the inclusion and exclusion type features? Who were the patients that went into this study?
Well, all patients with typical GCA clinical features. It could be new patients or relapsing patients. In fact, 70% were new, 30% relapsing. Well, they had to have a firm diagnosis, of course.
Does that mean a biopsy for everybody?
Not a biopsy for, I think about 40% of patients got a biopsy. Quite a lot of them had their diagnosis by ultrasound or PET scintigraphy. Like in GIACTA, for instance, 30% of patients there also got their diagnosis by PET scanning, for instance.
So the inclusions were over 50, new onset or relapsing.
Right.
They all got 40 milligrams of prednisone a day before the baseline, and were taking 20 milligrams and taking 20 milligrams a day at baseline.
Yeah.
You excluded if you had prior JAKs, if you inadequate response to an IL-6 inhibitor within a month,
right.
and chronic use of steroids. So there were 3 arms. Tell us about the arms.
So, so patients were randomized. 210 was the intention to be randomized to the upadacitinib 50 milligrams a day arm, 104 to the UPA 7.5 milligram arm, and then also 105 to the placebo arm. So the placebo arm was a standard of care, 52 weeks steroid taper. The patients on a dose of upadacitinib got only 26 weeks of steroid treatment.
So they started on 20 and they had to taper to 0?
Right, by week 26.
For the active arms and 52 weeks for the placebo. And then you're reporting the first period, the 52-week double-blind control, but you do have a second period, which is a blinded extension. What are you planning to do with those patients in the blinded extension?
Well, the main goal there is to see if you have to continue upadacitinib for more than 1 year, what happens when you stop it after 1 year or when you continue it after 1 year. So patients on one of the 2 upadacitinib arms who were in remission from week 28 to week 52, so without steroids and complete remission, they were randomized in a 2-to-1 ratio to continue upadacitinib or to be switched to placebo. The patients who didn't reach that 24 weeks remission without steroids, but who were in remission at week 52, well, the treatment remained the same. The placebo patients and the patients on the placebo arm, they were continued on placebo.
Okay. And you define remission as normal inflammatory markers and no symptoms. How is remission defined?
For the primary results, we're talking about sustained remission. This is remission without any flare from week 12 to week 52. And we also, so no symptoms for which the clinician thought he had to increase the steroids. And then there is the sustained complete remission. And this is no complaints of GCA, of compatible with GCA, and no raised inflammatory markers.
Okay, and your definition of a flare was a recurrence of symptoms or an increase in the inflammatory markers?
Yes, for which the clinician thought he had to increase the steroid dose. Yeah,
okay.
That's right.
And let's talk about the baseline demographics. They were 2/3 female.
Yeah,
you had tell us about those.
Well, it's a very classic GCA population. So mostly female, mean age of about 72 years old, and yeah, mostly white also. So it's
Yeah.
what we normally see in this population.
And the disease about 42 days, so fairly early on in their diagnosis.
Yes, but but this could vary from 15 to 3,000 or 4,000 days, because the relapsing patients, of course, were also eligible.
Included.
Yeah.
So you had about 2/3 new onset, 30%
Right.
relapsing.
Yeah.
The
That's right.
baseline steroid dose about 34. That's, they're quite high doses. For example, in our country, we start at 30 and bring them down rather than at much higher doses, but it's different around the world. Baseline ESRs and CRPs, you had about 6% who'd prior use of an IL-6 inhibitor, so they must have been off for a month and flared.
Right.
20% with some vision loss, so these are active patients, and about 60% with a history of PMR. So they, as you say, they're a very typical bunch of elderly patients, quite 30% over 75. So safety will be a big thing to discuss. Tell us a little bit about the primary endpoint and what the results were.
So the primary endpoint was the proportion of patients achieving sustained remission from week 12 through week 52. And significantly more patients in the UPA 15 arm attained that primary endpoint, 46.4% versus 29%, p-value of 0.0019. The UPA 7.5 arm was between placebo and UPA 15, and it just didn't reach significance. The p-value was 0.0579.
And the FDA always loves to push for the lower dose, so you probably weren't powered, but any numerical or nominal comparison between the 7.5 and the 15? Was there a significant difference between those two, even nominally?
I cannot answer this question for sure.
Yes.
Yeah,
because it's not powered.
No,
Fair enough.
no,
fair enough.
No.
But the 7.5 almost hit significance, just one or two more patients than it would have been. So tell us about your secondary endpoint.
Well, there were quite some secondary endpoints. I also told you, there sustained complete remission. So with the normalization of CRP included, and also there the UPA 15 milligram arm had a higher proportion of patients compared to placebo. Another secondary endpoint was the cumulative glucocorticoid exposure, which is also, of course, very important, and significantly less steroids were needed in the first year, 1,600 milligrams versus 2,900 milligrams in placebo-treated patients. And then there were, the proportions of flares, which was significantly lower in the 15 milligram arm compared to placebo. So they did, of course, less likely a flare. And then there was a lot of other endpoints. Well, 9 of 11 ranked secondary endpoints were met with the UPA 15 milligram arm. For instance, also FACIT fatigue score at week 52 was also significantly better in the UPA 15 milligrams arm.
So just talking a little bit more about those results, the 7.5 separated from the 15 much better in those secondary endpoints, with the 15 being significantly better a number of levels, 37 versus 26, for example, complete remission from 12 to 52. And again, significantly less steroid needed for the 15 milligrams than the 7.5. So they separate quite nicely there. Mm-hmm. Interestingly, what do you think of 34% still flaring on the 15 milligram, which I thought was a little bit high than I would have expected, but maybe that's what you do expect in real life.
That's what
when you do a steroid taper.
Yeah, that's indeed what well, with the steroid taper, it's even worse. More than half of them do a flare relapse. In fact, that's also what we saw with tocilizumab. We also saw flares there during the intake for the period in which they were treated with tocilizumab, and especially after the stopping of tocilizumab.
Yeah. So, excellent. I just wonder, do you have a feel for the timing of when the 15 milligram patients might flare? First 6 months, second 6 months, any idea when those flares happened?
The last patient, well, from the first period was analyzed, I think, well, he got his last visit in April 2024. So people are still.
No, I'd just be interested.
Yeah,
I'd just be interested if all the flares were after the taper in that second 6 month period. So maybe you'll have time to analyze that.
Probably will have been the case, I suppose. So that's what we see when patients are treated with steroids alone. Also, it's when they come to a dose of 4 milligrams or 2, or when they have stopped treatment for the next a couple of months or weeks are the most vulnerable for having a flare, of course.
You have a nice Kaplan-Meier curve that you showed in Vienna of the time to first disease flare through 52 weeks.
Yeah.
And I think the median time was 46 weeks for placebo and not available, I don't think, for the other 2 doses.
Mm-hmm.
So can you explain that Kaplan-Meier for me?
Yes, well, as you can see, the green line, so the UPA 15 milligrams, well, it's clearly better than the other 2 curves, the placebo and the UPA 7.5. When you compare, well, you should not compare it, of course, because these are different patients, different time. But when you compare it to Hyacta, well, but I sometimes heard that Hyacta looked better, but this is, of course, because they had also had a placebo arm in which steroids were stopped at 26 weeks. And of course, these patients did very bad. And that's why the active treatment looked a little bit better. But no, I think this is what you could expect from the study.
And it's interesting that 7.5 separated from the 15 after about 16 weeks. So that's just a little bit of assistance. And as you say, you had lots of secondary endpoints: sustained remission, sustained complete remission, cumulative steroid dose, time to first flare, and so on. So very positive study. So we better talk a little bit about safety.
Yeah.
Any messages as far as safety is concerned? 2 deaths in the placebo, 1 death in the UPA.
Yeah,
anything
that's right.
We need to know about that 1 death?
Well,
drug-related or not?
The 2 deaths in the UPA group, one was due to COVID, and in the other one we didn't know for sure from what he died, the patient.
And the adverse effects leading to drug discontinuation was lower in the
was
UPA
lower
15,
in fact, yes. Yeah.
Than the placebo or the 7.5.
That's right.
23% versus 33%. So that was nice to see.
Right.
And then if you go through some of the important adverse events, serious infections, there didn't seem to be any signal there. Placebo is the same as the 2 UPA doses. Did you have any zoster issues? There was a small number of zoster, of course.
Yes.
Yeah. Was there any mandation? Any mandation of vaccination, or what's the vaccination?
No.
No,
the patients were not vaccinated. That was not a requirement. Okay. No.
And the incidence looks like it was what you'd expect in an elderly patient population taking steroids and taking a JAK inhibitor.
That's right.
They were, with the 50 milligram dose, it looks like it was 7.3 per 100 patient years, compared to 4.3 with the placebo arm. MACE, there was no signal. VTE, no difference between significant difference between placebo and the two drug arms. No malignancy signal. What else did you have? What other safety things did you need to think about? Anemia, a little bit
anemia,
of anemia.
as could be expected. CK elevation also, but these things were expected, of course. And
yes.
well, yeah.
The anemia is interesting because it just suggests the higher you go with any JAK, you lose selectivity and start to get a bit of JAK2 inhibition. So it's interesting about that in the elderly population. So what else did you see? CK, a little bit of hepatic, but nothing much.
No.
Anemia. So very interesting results. Safety, nothing out of the ordinary.
Yes, and these patients were in fact 20 years older than the RA patients, and they had also a higher incidence of vascular problems in the placebo group also, and yet with the UPA 15 or 7.5, we didn't see any issues about.
Yes. So I would have expected a lot of infection because they're old, they're on steroids, and they're on a JAK. But in the first 52 weeks, that's reassuring. Did you have any? It's too early, I'm sure, for the analysis. But would you have had enough imaging to give us some information about imaging?
It's too early indeed, but we definitely need imaging. And that's maybe also for another reason, because as you may know, patients on tocilizumab, when you do PET scanning while they're taking it, or in about 50% of or so, you still see vasculitis on the PET scan, and of course this is something we hope would be lower with this drug, which also, of course, interferes with the interferon signatures. So that might be important.
Well, I'd love to see some imaging data. How many patients have got major artery involvement that we just don't even image to see most of the time? We just treat these people. And I'd love to know how many people in prolonged remission still have active imaging and how long it takes for imaging to reverse.
Yes.
They'd have only ever had one PET scan. They wouldn't have had two, would they?
I'm sorry?
They would only ever have one PET scan at entry.
Yeah. There was no second PET scan asked for.
That'd be lovely. That'd be great to see any change.
Yeah, well, yeah, indeed. Yes, I'm also very curious about that. There were some PET scans done, of course. I included 21 patients to this study, and so we had all of them got a PET scan at diagnosis, and there were also, I think, 11 PET scans done afterwards. Of course, mostly.
Would be very interesting.
Yes, yeah, it will be. Yeah.
So, what were your conclusions from the study?
Well, that it's an effective, apparently it's an effective treatment, and patients can get off steroids earlier and with lower doses. And they're all
with the usual safety caveats that we're used to with JAK inhibition.
Yes, of course.
And any take-home message? What if for a practicing clinician, the second year will be very important to know what happens as far as how long to treat for, but any take-home message?
Well, take-home message is, well, there is, apart from steroids and tocilizumab, it looks like there is an alternative for patients who have problems with steroid intake, for instance, or with tocilizumab. Yeah. Because
I just wonder how that's going to go with the EMA recommendations about over 65 and cardiovascular risk. All these people would have been old and have cardiovascular risk. So is it going to be different for different disease indications from the EMA?
I can't speak from EMA, but these our figures are very, very assuring that it doesn't add risks in these patients. But of course, as a physician, you also always have to look the patient before you, and there is can talk to him and explain the risks, and because of steroids also prolonged
risk, yeah.
intake of steroids is also very problematic.
And in the real world, we might use some zoster vaccination before we start.
Yes,
I think.
indeed.
Even the high-dose steroid before we start.
More. Mm-hmm.
So thank you for very much. Anything else that you wanted to comment on?
Well, yeah, I'm very curious about the second part of the study, and as you say, if imaging would also be very, very interesting. Yeah.
Thank you very much for your time, Daniel. Greatly appreciated. I think it's a very important study and may change practice in the future. Mm-hmm. So there's not many studies presented at EULAR this year that actually have the potential to do that. If you'd like to know more about this paper and others uploaded to the Immune-Mediated Inflammatory Diseases Forum website, you can get detailed slide sets are available in imidforum.com. Please subscribe to this podcast on Spotify, iTunes, and other podcast media, and let us know what you think. You can also watch us on Immune-Mediated Inflammatory Disease Forum on YouTube. And finally, you can follow us on Twitter, LinkedIn, and Facebook to keep up with all the newest data about inflammatory diseases, content coming soon in 2024. Thank you so much for your time. Greatly appreciated.
Thank you. Bye-bye.